Hello and welcome to Conversations with Dr. Bachner. As I say each time, this is indeed Dr. Bachner, Howard Bachner. I'm editor-in-chief of JAMA. And I'm so excited to be joined by Melinda Buntin. Melinda, along with John Ayanian, our founding deputy editor and editor-in-chief of JAMA Health Forum. Melinda joined Vanderbilt in 2013 as professor and founding chair of the Department of Health Policy, and in March 2018 was appointed the Mike Kerb Chair for Health Policy. John is the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy, the Alice Hamilton Collegiate Professor of Medicine at the Medical School, University of Michigan, and Professor of Health Management. He is the inaugural director of the Institute for Healthcare Policy and Innovation at the University of Michigan. Welcome, Melinda. Welcome, John.
Thank you.
Thank you, Howard.
So before we start, Melinda, can you tell me what does the Congressional Budget Office do?
Well, you didn't mention that where I was before I joined Vanderbilt was the Congressional Budget Office. And the Congressional Budget Office is in charge of determining the fiscal impact of any piece of legislation, major piece of legislation moving forward in a Congress. I worked in the health arena, and there were literally billions of dollars worth of bills every year that my group had to be part of evaluating. We also have a whole fleet of PhD researchers, mainly economists, who study long-term trends and build models so that we can be prepared to answer any questions that Congress comes to us with about the fiscal impact of health legislation. And you can tell from the fact that I just used the word we, that the CBO has a very strong culture and is very proud of the nonpartisan work that they do. And you carry that with you when you're a CBO alum.
So you kind of price out things and then give the information to Congress?
Absolutely. Although the CBO realizes that as one of the few truly nonpartisan bodies around, the public is a big consumer of CBO reports as well. So they'll often be reported in the media, and we get inquiries from citizens as well.
Well, given the activity around finances in Congress, I suspect they're very busy at the moment.
Absolutely. Absolutely. $2 trillion stimulus packages are a lot of work.
So, John and Melinda, you're the founding leadership of the JAMA Health Forum, so thank you for joining the JAMA family. So for people who are hearing about this for the first time, we've tried to create a very different health policy product called the JAMA Health Forum, and John and Melinda are the founding editors. And what we're trying to do is collect all of the health policy content across the network, obtain some new blogs and opinion pieces, and then have John and Melinda curated in very unique ways. And they have a partner in all of this, Joan Stevenson, who's been very good about following the news of health policy. We're here to talk about COVID-19 and some of the major health policies that have emerged just over the last 6 weeks. So John, let's start with you. If I had to ask you what was the single most remarkable health policy that's come out of the COVID-19 pandemic, short of the $2 trillion stimulus package, what would you say it's been to date?
Well, I think it's been the recognition in what ways our healthcare system is resilient, and the way we've seen it in states and cities and regions around the country, healthcare leaders and community leaders, political leaders coming together to address this sudden surge in demand for critical care, the substantial risk of mortality and morbidity that we've encountered with COVID-19, and understanding what are the strengths of our system in that resilience that we've seen, but also what are some of the substantial limitations in the way our healthcare system can often be very fragmented, and we have some limited ability to share information and resources in a crisis like we're experiencing now. I think that ability has improved a great deal over the past month, but it really unmasks some of the challenges that we have in meeting a very critical time of healthcare need in our healthcare system that we've seen others experience around the world.
Melinda, have there been specific legislative policies that have changed that have impressed you?
So I think one of the most impressive things about this experience with COVID-19 is how people have responded to really unprecedented social distancing ordinances, whether implemented at the state or local level. That's really amazed me. And it's also shown us sort of the challenges, but maybe also the flexibilities of federalism, because these decisions were being made jurisdiction by jurisdiction and then state by state. And there's a lot of variation, which means that all leaders at so many different levels are being faced with these questions and learning to draw on their public health infrastructure and expertise in ways that they never have before.
Now, the large three payers in the U.S. are Medicare, Medicaid, and the private insurance. Obviously, the VA has an entirely separate system, so there's really four large providers of care: Medicaid, Medicare, private insurance, and the VA. Have there been specific changes in Medicaid, Medicare, or private insurance in response to COVID-19?
Go ahead, John.
Well, Howard, I would point out the sort of a rapid adoption of telehealth that we've seen and payment mechanisms for healthcare systems at a time when they're asking people to stay at home and shelter in place, but there's still a substantial burden of chronic illness unrelated to COVID-19 that we need to continue caring for. I'm a primary care physician at the University of Michigan, and we've rapidly switched to treating our patients with telephone visits and video visits, and really limiting those coming in for face-to-face visits to those who have some urgent problem that needs to be treated in person or that may require hospitalization. So that's been a profound change. I think we've made more progress in implementing telehealth in the past month than we might have in a 5-year period without COVID-19 and the crisis it's caused.
What have been the payment changes, John?
That we're now able to bill for telephone or video visits in a way that was not widely adopted even just a month ago. And that's required cooperation with all the payers that you've mentioned, with the private insurance payers in all regions of the country, as well as the major federal programs. And, I think we're still working through those processes, but, we now have new codes and new guidelines for physicians to get reimbursed for those virtual visits, we call them, either by telephone or video technology.
Melinda, have there been other financial changes to policies that have been striking to you?
Yes. Well, one thing that most of us in the health economic community and certainly the medical community have known for a while is that co-payments and deductibles can be real barriers to accessing care. So the decision early on at the federal level to say that testing would be free for individuals and that co-pays and deductibles would be waived, I think is a really national level recognition about cost being a barrier to access to care. And maybe that will be precedent setting, not just for a community danger like a transmissible disease, but for other things which sort of threaten the health of our communities in other ways. I also think that the rapid response in the stimulus bill to making payments, sort of interim payments to hospitals and doctors is striking. I know many different medical providers got direct deposit last Friday, huge relief that they would have cash flow based on those federal stimulus payments. So that's also an unprecedented change and could bode well for fixed payments to cover other types of care in the future.
It was striking at our research meeting this morning. One of our associate editors lives in Maine, and his significant other runs a small practice. And she was able to get the small business loan like in a week. Mm-hmm. And she's able to pay her employees. Mm-hmm. I said, really? Like, she got a lot of money to pay her employees. It was fantastic. Is that part of this $2 trillion?
Absolutely, yes. Yes, it is.
Now, John, you and Melinda over the last month have probably commented or published about 15 or 18 pieces related to COVID-19. What are the ones that have stood out in your mind?
Well, one of the earliest that we published was by Joseph Cavallo and colleagues reporting on how hospitals could prepare for the surge in capacity that they would be facing. It was really predicated on what we were seeing coming out of Italy. I know JAMA was publishing some of the early reports about the shortages of critical care and healthcare workforce, doctors, nurses, and others becoming infected and that putting further stress on the healthcare system. And so about a month ago, we published a piece titled Preparing for the Nth Patient around hospital capacity and operations. And I think that was an important harbinger really to help capture the attention of our health system leaders and clinicians on the front line that we were about to face a tremendous surge of demand for hospital and particularly critical care in some of our major metropolitan areas, as we've seen in Seattle, New York, Detroit, and New Orleans as some of the early affected hotspots. And it really laid out a framework for how health system leaders could think about preparing. As the authors talked about, hospitals are built for average capacity. They're not built for a surge. And the way we've seen hospitals adapt by canceling or postponing elective surgery, converting spaces such as OR recovery areas into intensive care units and to expand their ICU capacity has been part of the way we've been able to blunt the effects of this surge in demand for hospital care and intensive care particularly.
Melinda, given what you've seen come across your desk, because I know you two split the looking at the content and then commenting on it, what struck you in what you've been publishing at JAMA Health Forum?
Yes. Well, the first piece that comes to mind is one that actually the excellent Joan Stevenson handled. It was a JAMA Health Forum piece by David Cutler looking broadly at the financial effects of the pandemic and whether it could cause a protracted recession and what the implications of that would be for the health industry. So I recommend that one. Another one that comes to mind is a more recent one published on testing. When we think about the sensitivity and specificity of the existing tests, how little testing there is going on compared to what we might need. And when we think about how we will reopen the economy in the absence of widespread testing, I think that's an important one as well.
I'm wondering, both of you do health policy and health economics. And, I think I've spoken to both of you. Even before the pandemic, I was increasingly concerned that we were nearing the end of this extraordinary economic boom and that state coffers would become more limited. And when I first arrived at JAMA in 2011 to say 2015, there was so much written about the cost of Medicaid, which is shared with the states. And then as the economy got better, that sort of went away. But then New York, before the pandemic, was going to have a huge deficit, and the governor was reporting that much of it was due to Medicaid. Well, state coffers aren't going to be very good this year, and Medicaid remains, depending on the state, shared burden with the federal government. What's your impression from the two of you about what's going to happen with Medicaid costs at the state level?
Medicaid costs will undoubtedly increase, but that's a function of Medicaid being such an important part of our safety net nationally and in all the states where it exists. There are states that have chosen not yet to expand Medicaid under the Affordable Care Act. I'm concerned that low-income adults who are uninsured will hold back from getting care in states where it's much more difficult to enroll in Medicaid, and that could actually compound the epidemic if people stay home with symptoms and don't get the care they need and then either suffer themselves or spread the coronavirus infection to others in their communities. So I think we have to recognize, particularly in a crisis, how important Medicaid as well as Medicare are as part of our social safety net in making sure people get the care they need and have the best chance for a good health outcome.
Melinda, what's your sense of what will happen with Medicaid costs going forward?
Yes. Well, most states can't do stimulus bills because they must balance their budget on an annual basis. And so before, for example, the state legislature left here in Tennessee, they passed a budget out of concern they might not be able to return. They did it very quickly, and they had to really pass a bare bones budget out of fear that their revenues would decline so much and there would be so many additional burdens on them that they wouldn't be able to afford what had been in the budget proposed by the governor just a month before, really. So state budgets will undoubtedly be taxed. The Medicaid programs will be taxed by greater unemployment rates. And this will all lead to additional pressures. I think what we're talking about now in terms of stimulus bills on the federal side are wave 1 bill, wave 2 bill, wave 3 bill. We're going to have to see how many waves of stimulus we might need, and there might be one that's focused particularly on this issue and the problem states are going to have affording their Medicaid programs.
So so these wave bills, we're not done with them.
I doubt it.
Okay. I spoke to Mike Leavitt last week, former governor at Utah and head of HHS, and it was really interesting. He said major world events have consequences well after the event ends, and he pointed out a number of them. Obviously, the Great Wars and so forth. And he thought we can't quite yet anticipate what the long-term consequences will be of this pandemic. Do either of you want to take a shot at it vis-a-vis healthcare?
Howard, that's a great and tough question. I think, in the immediate aftermath, we're going to have to think about how we restart the healthcare system and address all the needs that have been deferred or postponed during this crisis phase when we've asked people to shelter at home. I think we're going to have to start integrating public health and healthcare delivery much more effectively. I think historically those have been, at least in the United States, there's been too much of a division between public health and healthcare delivery, and public health services have generally been underfunded in recent decades at the state and federal level. So I think this really points out why we need a strong public health system and why it needs to be connected and integrated with our healthcare delivery, because we're starting to understand some of the limitations we have in terms of tracking the epidemic and following up on people with positive tests, which are traditional important functions of a public health system. So I think that's going to be one of the earliest challenges that we need to address coming out of this, that we can't just go back to the existing system because we'll likely have further crises like this in the future. We're living through one pandemic, that maybe is on par with what was experienced with the influenza pandemic in 1918. But I expect the next challenge like this is going to come much sooner than a century, as it was in this case.
Melinda, do you think the revolution that's occurred with telemedicine, telehealth, that the payers will continue to fund it, and that will just be incorporated into normal care?
All the providers that I'm talking to are saying that telehealth is the genie that's out of the bottle and it's never going to get back in. And I think that there'll be a lot of patient demand for that as well. Previously, it was a theoretical, it sounded nice. Now many people have experienced it and found it better. They also will probably feel better about getting a telehealth visit when they can, rather than visit a place where there may be other sick patients. And I can tell you, I'd rather wait in somebody's Zoom waiting room than an actual waiting room, especially given what I've learned about virology recently.
Now, we have the large payers. We've already talked about them, Medicaid, Medicare, and the private, and then obviously the VA. But then the recipients of that are 3,500 hospitals, skilled nursing homes, and then small practices and large multi-specialty practices. Let's start with the hospital side, and then we'll get to the practice side. Will they survive? I mean, they're going to have pent-up demand. They'll begin to bill for critical care. At some places, like at UPMC, they haven't had much disease. They're doing less care. So their upward billing for critical care may never happen. So what's going to happen on the hospital side? So one of you need to take the hospital side, and then one of you are going to have to take the practice side.
John, choose first.
So, Howard, I'll talk about ambulatory practices, primary care practices, specialty practices. I think some of the small business loans that you referenced earlier will help them to get through this acute phase. But, I think how they prepare for a future crisis will be an important part of the recovery. I think we also are learning about how we expect our frontline healthcare workers to be adaptable and to take on new tasks. There's been a lot of repurposing of healthcare workers in our health system, people who mainly focus in the outpatient setting, taking on more inpatient responsibilities. workers, helping with, say, respiratory therapy care in the hospital that they wouldn't normally participate in. So I think we're going to have to think about how we maintain that skill base and how we plan, because we've done all this in the past 6 weeks or so, very much on the fly, each local area, each local practice and hospital sort of adapting its workforce to local needs. But I think we can learn from that process and understand how to build more surge capacity into our system so we're better prepared for the next crisis when it arises.
Melinda, what do you think is going to happen on the hospital side?
So health economists have been worried for a number of years now about greater consolidation in general in the healthcare industry. So consolidation of hospitals, vertical integration where hospitals buy practices that might refer to them and the like. And I think that is going to be accelerated by this crisis. The well-capitalized, larger hospitals are going to be able to weather this very difficult storm. Others may be very vulnerable and good targets for acquisition. So I just think consolidation will be one major byproduct of this. I also really worry about primary care practices that are independent. I just don't know if they will get enough out of the stimulus bill to be able to stay open, or if they'll feel that they really need to affiliate to be more financially stable in the future.
Now, I don't know where I was, but someone said, did you know that the nominee, Vice President Biden, just said he wants to lower the age of Medicare to 60. I don't know where I was. It wasn't in any of the feeds I normally get. That's been suggested before, that one of the ways to ensure more and more people is to lower Medicare. It's generally considered a reasonably efficient payer. It pays reasonably well. Medicare Advantage has generally gone well. It's about 35 or 40% of Medicare. So in some regards, Medicare today is not like Medicare 10 years ago. There's a very large private component to Medicare that didn't exist even a decade ago. What's your reaction, both of you? What's your reaction to lowering Medicare to age 60?
Please, Melinda.
Well, I would say that, this presidential campaign, even though I feel like I've been only reading about COVID for years now, the presidential campaign is going on, and it's going to be very important to all of our lives, and we will return to more regular coverage of that. It brought up so many issues about Medicare. If we were having this conversation 2 months ago, I'm certain we would have been devoting time to Medicare for All, for example. Right. Now we're in a period where Sanders has dropped out, and Biden, who really had the plan to most build on and continue the Affordable Care Act and Obamacare, is going to be the nominee. That said, we've spent a lot of time in the academic community looking at these types of options for building on Medicare as a platform for expanding coverage. And so I was part of an expert panel that was looking at that. And when you look at it technically, you can say that if you want to expand coverage using Medicare as a platform, lowering the age of eligibility is one of the most easy and technically feasible ways that doesn't have as many adverse consequences for the rest of the health insurance industry.
Now, I'm Medicare eligible, but I still take private insurance. So is that how it would continue to work in Biden's plan?
There are different plans, and I actually haven't looked at his specifics. So, and the devil is in the details there. And what it would mean for other sectors that goes from one sector to another.
John,
Howard, I would just...
Yeah, what was your reaction?
A lot of my own research has been on health equity and health disparities, and with other colleagues looking at the health of middle-aged adults who often are at greatest risk of being uninsured, whether before or after the Affordable Care Act. And what we find is that that's the group, the adults over age 50, where the prevalence of chronic conditions like diabetes, high blood pressure, heart disease, kidney disease, that we have great treatments for, but people need to have access to care, both financial access and structural access to care. That's where the benefits of health insurance are likely greatest. And so I think it's a quite reasonable policy proposal to consider lowering the age for Medicare. It should be an active debate in Congress about how we pay for that and how it's structured in relation to private insurance. But we know from a health standpoint that many people benefit from making sure they have consistent coverage after age 50, and particularly as they approach age 65 when they would otherwise become eligible for Medicare.
John, do you think that debate, that discussion has become easier because of Medicare Advantage? Because now there is a private option within Medicare. So so much noise isn't the right word, but so much information crosses my desk and the objections to Medicare for all. But at 40% private insurance, it's not what it was 10 years ago. Do you think that makes it an easier discussion to have in the United States?
Potentially, and I think that's the debate that we need to have in Congress is, what mix of traditional fee-for-service Medicare or Medicare Advantage would be offered to middle-aged adults if the age of eligibility for Medicare was reduced to 60 or 55, or some proposals would recommend taking that eligibility down to age 50. It might initially only be offered to people who did not have another source of coverage. So people who were employed and had stable employer-sponsored insurance might be encouraged to remain in those plans. But for people who didn't have other options, either because insurance is not offered through their employer or they are not working for health reasons, but they're not severely enough disabled to qualify for Medicare based on disability, those are the groups who would especially benefit if Medicare, the age for Medicare is lowered. In some states that have Medicaid expansion, adults in that age range with lower incomes are benefiting from Medicaid coverage. I think we can also think more creatively about how to integrate Medicaid and Medicare for the large number of dual eligible Americans that we have who qualify for both programs.
Melinda, your comment about just reflecting on what John said about, reducing the age of Medicare, increasing eligibility for Medicaid. The number of uninsured went up last year after having dropped for 3 or 4 consecutive years, and it's growing again. I suspect it will grow again this year. I mean, what's your sense about lowering the Medicare age eligibility and expanding Medicaid eligibility? Is that a way to close the gap to ensure that 25 or 30 million people who remain without health insurance in the U.S.?
Well, those would clearly be the easiest and most practical ways to expand insurance. It's building on the systems we have and trying to mesh them together to cover people who fall through the gaps. And I think that we, will almost certainly be declared in a recession in a few months. Yeah. We know that hundreds of thousands of people are losing their jobs and their health insurance coverage during a period of time when they're very frightened about their health. So health was already going to be one of the top issues in this presidential campaign, and there's no way that it doesn't rise even higher on voters' lists of things they'd like to see more action on. So I would be shocked if there weren't more discussion of these types of options.
So the two of you became editor-in-chief and deputy editor before there was a pandemic. It was an entirely new product. You often ask me, well, what do I think? And I said, well, I'm not so sure. We're good at starting traditional journals, but this was an entirely new venture for us. We were really trying to do something very, very different. How is the pandemic, how's it made you think about running JAMA Health Forum? I can't crystallize the question enough, but I'm sure you're moving along. We're doing really well. You're publishing great. And then all of a sudden there's this pandemic. Well, how have you reacted being at JAMA Health Forum, a new product, and then along comes this remarkable health event?
Well, Howard, I think it's given us a strong sense of purpose. Obviously, a lot of thought and effort went into planning this new platform, JAMA Health Forum. We launched in late January. Right from the outset, we've been getting great content submitted by authors around the world, and we've been excited about reviewing that content and bringing it forward, as well as featuring some of the health policy content that's published across the JAMA network. I think about 6 weeks ago, when it became apparent that the pandemic was going to affect the United States severely, I think it really bolstered that sense of purpose we had, that we needed to be faster, more nimble, and more responsive in getting health policy content out to readers and policy leaders, health system leaders around the world from our talented community of contributors. So that's been exciting. We've all had to focus on our purpose in the healthcare system over the past period of weeks and months as this crisis has taken hold. But I view the sharing of timely, accurate, insightful information as one of the greatest resources that we have in our healthcare community. And my hope is that JAMA Health Forum is contributing to that goal.
Melinda?
Well, I completely agree with John, as usual, which has been a great part of this new position for me. And I will also say that one of the things that I've taken into all parts of my work life now is how well the JAMA team works together with us remotely. So interacting this way via video, exchanging emails, having chats, dealing with things efficiently at a distance. We were all doing that so well already because the team is so talented at the JAMA network. And I've tried to carry that into all the other aspects of my projects I'm working on. And that's been really something to build on.
Well, when we began to think about doing this, about a year or 18 months ago, as I often do, I emailed, 8 or 10 people, and I said, well, like who could take the leadership reins of this new product that we hadn't done before? And I have to say, Melinda and John, your names popped up more on the lists I got than anyone else. So, I can't thank you enough for committing to JAMA Health Forum. This is Howard Bachner, Editor-in-Chief of JAMA. This has been Conversations with Dr. Bachner. I've been talking to Melinda Buntin. Melinda is the Mike Kerb Chair for Health Policy at Vanderbilt, and John Ayanian, who's the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy at the University of Michigan. Melinda and John, thank you, and stay healthy.
You too, Howard. Thank you.
Bye-bye.
Thank you, Howard.